Hello, and thank you for joining me today at a different time. We're 7 p.m. Eastern US because we've got a very special guest, Dr. Barry Raphael, who is practicing at the Clifton Orthodontic Centre, the Barry Raphael Centre for Orthodontics. And he's a good friend, and I'm really excited for this chat because Dr. Raphael is one of the most forward-thinking practitioners in the space of expansive and myofunctional orthodontics, and I'm really excited to share his story. Dr. Raphael, thank you for joining me today.
You're so welcome. It was so good to hear from you again. We saw each other a few years ago when you came up and toured the U.S. Your book had just come out, and we were very excited about that because we hadn't really had a good reference for for the nutritional aspects of this. And I people do call me forward thinking, and for me, I definitely had moved forward from where I was 10 years ago, but I'm not so much alone anymore. And there are a lot of people that are thinking this way, and a lot of Aussies too.
Yeah, absolutely. And you know what, you bring up a great point because, we're talking about, how we address the problem of malocclusion and crooked teeth in children for parents that are thinking about it. But, why don't we take people back to those moments 10 years ago when you were, back in your practice, and what were the moments that's made you start to think about this differently?
Yeah, so I had been in practice for 27 years already. As an orthodontist, I loved orthodontics. I loved straightening teeth, putting on braces. Taking braces off was always, a celebratory affair. We'd sing, we'd take pictures. It was great. It's a big moment in a kid's life when they get their braces off. But there were always certain problems that orthodontists face and still do today. There's certain things about braces that, let's say they're not perfect. And for one is that when you take braces off, teeth don't always stay where they're put. And so everybody knows this about braces. You have to put on retainers to hold the teeth in place, and essentially you've got to wear the retainers forever. In fact, a lot of orthodontists now glue a little wire to the back of the tooth just to keep them straight, because they don't want to hear, I didn't wear my retainer, I threw it in the garbage, this and that. It's a pain for them, and people pay good money for braces. The parents don't want to hear that the teeth are getting crooked again. So that was one thing, but we live with it, and most people accept that. The second thing is that there are certain things that happen in the human body that braces just don't take care of. And for the major example, it's the action and activity of the tongue. The tongue, by and large, is kind of that 600-pound gorilla in the room. It is responsible for the way the bones grow, the way the teeth come in, and it's also responsible for the teeth not staying straight afterwards, right? So we kind of know this, but to tell you the truth, most orthodontists, they just don't even bother with the tongue. In fact, most dentists, the only concern they have about the tongue is keeping it out of the way so that they can do their work, right? We just want to hold the tongue aside while I put you just sit over there while I put the braces on, right? And it frequently interferes with the final results of the braces, in that if the braces are trying to move the teeth in one direction, but the tongue is pushing the teeth in the opposite direction, well, guess what? Guess who wins? And it's almost always the tongue. So orthodontists will tend to fight off the tongue by putting in things like fences, physical barriers to keep the tongue away from the teeth. They'll put in spikes and rakes and little, gadgets to try to ward off the tongue, keep it away from the teeth. and tell you the truth, it may work while those things are in place, but it just doesn't stay. So I had a case that morning where I had what they call an open bite. That is, trying to bring the top and bottom teeth together, but the tongue is in the way, and you just can't get the top and bottom to fit. And I sat down for lunch, just as frustrated as I always am when I have those situations. And I happened to read an article in one of the industry rags by a guy named, and you'll know this name, Herman Ramirez. Right? Herman is a dual degree orthodontist, pediatric dentist, now up in Ontario. And the article said something that I kind of knew but didn't really know. And that is, he said, soft tissue dysfunction is the cause of crooked teeth. Soft tissue dysfunction. And I think actually when I created slides about it, I capitalized THE. Now everybody knows that the tongue can mess up the teeth. Everybody knows that thumb sucking can mess up the teeth. Everybody knows that pacifiers mess up the teeth, right? What do you call pacifiers? Dummies? Dummies. Yeah, the dummies can mess up the teeth. But for the most part, orthodontists think that that's just, sort of a small percentage of the cases that go on. What Herman was saying is that soft tissue dysfunction is the cause of malocclusion of crooked teeth in every case. Well, I mean, some people have extra teeth. Some people are missing teeth. They never form. Some people lose teeth, to decay, especially if you lose baby teeth early. All those things, they tend to gum up the works. So maybe that's 10% or 15%. But for the vast majority, and it took me, I have to tell you, Stephen, it took me 6 months of thinking about this to really understand that Herman was right. That soft tissue dysfunction is the cause of malocclusion. Now, there are other things to consider, like, why do people have soft tissue dysfunctions? Why do people breathe through their mouth? Why are their tongues lying low in the mouth? Why do people suck their thumbs? We always assume it's just something kids do. It's normal. But no, all these dysfunctions, they all serve a purpose. They are generally what we call compensations for problems, meaning that we adopt a lot of these behaviors because we're having trouble with something physically. For instance, if you can't breathe through your nose, you've got to find another way to breathe, right? If you have allergies, you have congestion, you have sinus infections, you have, all kinds of things make the nose. You have a narrow nose, you have a small nose, your cartilages are collapsed inward. All these things can make it harder for you to breathe. What are you going to do? Well, you got to take the next breath, right? That next breath can't be through your ears. The only other place we could breathe through is through our mouth. So we open our mouth. What happens then? In order to breathe through your mouth, your tongue has to lay low, get out of the way. If your tongue is on the palate where it's supposed to be, you can't breathe through your mouth. Now you start having this vicious cycle where the tongue lies low, the air's going in unfiltered into your lungs. Your palate, which needs the tongue to take its shape, is starting to collapse inward. This is one of the pictures that I want to show you tonight. The palate starts to collapse inward, and now you get this run-on effect where your jaws are not forming properly. There's not enough room for the teeth. The teeth come in crowded. You're not breathing well. often not sleeping well as well. And you not only get the physical problems that occur from not breathing well, but you get the mental problems and the other whole body problems for not sleeping well. And you've probably had other guests on your show that have put this, you know, form and function spiral together, right?
Yeah, absolutely. Yeah, it's a real complex picture. And, you know, I'd like to just echo your experience about the soft tissue, how much of a change of mindset that is for someone that's been trained in dental and in your case in orthodontics. It just did not hit my my brain in a way that resonated, and it took me so long to realize that, hang on, so the tongue is changing the way the teeth, the bones, the bones don't do that.
Yeah.
And it was just a complete change of mindset. So, and how, so you mentioned that in orthodontic training, you know, there is this identification that the tongue has a role in this, and obviously in open bites.
Yeah.
So where do you think the gap in knowledge is, where this idea of how crucial soft tissue is with the formation of the dental arch, and where is that missing, and how do you think this can be kind of changed?
Well, those are two different questions. So let's deal with the first one first. By and large, orthodontics is a mechanical endeavor. And orthodontists are tooth mechanics. There's no doubt about it. We operate under the guise of, under the influence of Newtonian physics, Newtonian mechanics. For every action, there's an equal and an opposite reaction. I mean, it's all about, you're pushing on one thing to get a reaction on another. You're pulling on one, you're pulling on another. And the modern braces, and there are all kinds of ways of moving teeth now, they're all about the mechanics of moving teeth, by and large. And the struggle, not the struggle, but the challenge for orthodontics in these past decades is, how do we do that faster, more efficiently, more cheaply, more profitably? And there's so many incredible advancements in that way that it's getting easier to move teeth. The braces are better looking. They even don't even have wires, some of them, like the aligners and all that. They're more comfortable. They don't cause the soreness they used to cause. But this chase for the mechanical perfection had a downside, in that if we ever had to rely on cooperation from a patient, it would get in the way of the efficiency of the treatment. So we would look for all kinds of ways to take the level of cooperation out of the patient's hands. I mean, if you talk to any orthodontist about their worst results, they will start telling you about how the patient failed. Not how we failed, but how the patient failed. They didn't wear their rubber bands. They didn't brush their teeth. They didn't wear their headgear. They didn't come for appointments. They didn't wear their retainers. And while that stuff can be true, it sort of belies the fact that the human body is not a mechanical thing. And so we've kind of, and I'll talk about that in a second, because that comes, addresses that second question of how we're going to change this. We've boxed ourselves into a corner by chasing the mechanically perfect solution, and not addressing, by trying to avoid anything that smacks of behavior change or training or any of that, because it just doesn't fit into our paradigm. But the truth is, and I mentioned the word compensations, the origin of these problems lies in behaviors. And it's the same, look, the same thing is true in medicine. Same thing is true for diabetes, obesity, metabolic disorders. You know this as well as anyone, Stephen. The scourge of chronic diseases that we are facing that cause 70% of deaths worldwide are all from things that we could prevent if we did something differently. If we ate differently, if we slept differently, if we exercised differently, if we used our bodies differently, if we handled stresses differently. And yet medicine also got stuck in the, just the paradigm of taking care of symptoms. You got a pill, you got a surgery, we want it fast. I don't want to have to do anything, just fix me. And that's really what orthodontists are doing. So why is that not working? Because the body is not a it's not a machine. It is not a car. Yeah.
I think you described that really well, and we have to say that orthodontics is an incredible speciality. Like using Newtonian physics to align teeth is a very special skill, and it seems that like there's been such a focus on how difficult that skill is, obviously including patient compliance, that has been the focus of the speciality. Exactly. But then there's this uncovering of how reactive our body is, even to the point where we are molding our hard tissues, our teeth and skeletal system. Amazing, isn't it?
It is. It is. I mean, if you understand that soft tissue dysfunction is the cause of malocclusion, how do you change soft tissue? You can't push on it. You can't mold it. The only thing you can do is train it.
Barry, on that point, there's just a question here that I might bring up because it's relevant to what we're talking about now, and it might just help some people start to think about how they can change these habits in their children. So Jessica says that my 5-year-old always keeps with her mouth open, and I don't know how to help her change that bad habit. Yeah. Can you just describe, I mean, this is something obviously you see a lot, and it will help us kind of talk a little bit to describe, what parents can start thinking about in their children. But how do you address this when people walk into your practice with this problem?
So and I'm not going to be facetious here, Jessica, this is a great question. And I'm going to credit an Aussie with the answer, because I learned, this is, Herman Ramirez was he was the research arm of an Aussie company called Myofunctional Research Company, developed and headed by Chris Farrell on the Gold Coast and Sydney now. And he addressed this problem some 35 years ago by saying we need a way to train kids to do 4 things. We need to train them how to breathe through their nose. We need to train them how to keep their lips together and their tongue on the roof of the mouth. Those are really the big 3. And the 4th is learn how to function with your tongue properly, how to swallow, keeping your tongue on the roof of your mouth and not need to recruit the facial muscles, the lips, the chin, the cheeks, the neck, the blinking eyes that kids often recruit to help them deal with a tongue that's not working well. So he developed a very simple technique that uses an exercise accessory that he calls a myobrace. And I call it an exercise accessory because I'm thinking of things like, say, a jump rope or dumbbells. We use a jump rope or dumbbells to help us become healthier. They are an accessory that we use to become physically fit. Does the jump rope make you physically fit? No. Do the dumbbells, if you have them sitting under your bed, make you physically fit? No. You have to use them, and you have to use them in a way that's going to make your muscles stronger. There is no easy way. There's no pill, no potion, no vibrator that you put on your muscles to make them contract and become stronger. Jessica, The only way to teach your child how to close their mouth and breathe through the nose is to teach them how to close their mouth and breathe through the nose. And you can use an accessory to do it. His was called the Maya brace. Did I say that already? And it looks like a sports guard. I mean, it's got some cool features in it that allow you to you have to stretch the lips over the front to give it a little more tone. There's a little target for your tongue, but you have to get the kids to do it. They have to hold their lips together, breathe through the nose. Look, Jessica and everybody out there, we teach our kids to do a lot of things that are much more difficult than closing their lips and breathing through their nose. We teach them algebra. We teach them soccer. Football. We teach them piano. We teach them gymnastics and dance. How do you get a kid to do a flip? I mean, if you never tried to teach a kid to do a flip, they couldn't do a flip. But if you break it down into simple parts, start with, 1 foot forward, then the other, raise your arms, little by little, they learn. And it takes years. It takes years to train a child to be a gymnast. It can take just a couple of weeks to teach someone how to breathe through their nose.
Absolutely, you describe it very well. That it's a behavior, and parents are very, they're either in the situation where they don't know it's a problem, or they feel a bit hopeless. So you're kind of saying that this MyBrace system it's a silicone guard mouthpiece system that they wear at night, and it trains them to breathe through the nose and also puts them in correct oral posture. And so these things can help. But there's also really, because the big thing about these programs is that they have to learn the behaviors that change, how they think and use the mouth as well, right? And it's totally it's a complete mindset. It's difficult, and you kind of describe this with why orthodontic treatment don't traditionally do this, is because it is hard. You do have to kind of commit the family to thinking about how breathing integrates into a child's life. It's fascinating.
Listen, let me just say this, and I'm Jessica, I'm not picking on you by any means. Everybody out there that has never heard about this approach will ask the same questions. But my question for you is, how are you going to get your child to brush their teeth? Right? Would you consider not letting your child brush their teeth? Would you say, oh, he doesn't like the toothbrush and therefore he does not have to do it? You wouldn't do that. You're going to make your kid brush their teeth until they like brushing their teeth, and they'll do it on their own. Maybe, if it's a boy, it may not happen until he's in 8th grade and starts to like girls. I don't know. But you don't quit. And it's just not part of the culture yet that breathing and oral posture and function is as important as oral hygiene. And once it becomes part of the culture, these training devices, and MyoBrace is really just one of many around the world, people that are trying to do the same thing, they will be as ubiquitous as toothbrushes. Everybody has a toothbrush. Everybody at least knows they're supposed to brush their teeth twice a day. Someday, and someday soon, everybody will know they're supposed to breathe through their nose, and that their tongue is supposed to rest on their palate while they're growing up. Otherwise, their face will not grow properly and their teeth will come in crooked.
It's a great point. And the behavioral changes, parents, understand that this is a long-term change, and that, this is an investment into your child's future. It really does, change how you think about that. And when you see these kind of behaviors. Dr. Raphael, what do you think about, so there are children that have behavioral habits towards mouth breathing, but there are also children that are in the category of anatomical and sleep disorders. And so kids who snore and kids who have physical issues with their in the maxilla, with their palate, that makes it for them very difficult to breathe through the nose, and they snore at night. What is your approach or what is your suggestion for parents when they consider this? And how does this relate to the growth of the dental arch?
Right. So there are three things to consider in this whole piece. One is structure, one is function, and one is behavior. So we talked about behavior in that you've got to train the right habits. When it comes to structure, we're talking about what has happened to the facial structure, the anatomy. The anatomy as a child's been growing. And if function has been good, then anatomy will be better. But if function or behavior is not good, then there'll be damage, literal damage to the progression of growth. And the jaws will not fully fill out. We know this is the case because when we look back on skulls of just a few hundred years ago, we realize that kids and adults, they never had crooked teeth. Not never. There's some rare exceptions, but most had very little crooked teeth, and most had big and wide and broad jaws. And so what we also have come to see is that those same jaws that are needed to provide room for your teeth, when they grow big and broad and wide and forward, you also have more room in your nose, because the roof of the mouth is the floor of the nose. And they have more room in the back of their throat, because the airway, the passage behind the nose and down to the throat, is bigger. And you know, the interesting thing is that there is this relationship between crooked teeth and airway that a lot of orthodontists are resisting. They don't want to hear that. And there's not, and studies are a little bit equivocal about, you know, do crooked teeth cause an airway problem, or does an airway problem cause crooked teeth? The problem with this line of thinking is that they do not cause each other, but they are both caused by the same thing. That is, poor facial growth leads to smaller jaws, and smaller jaws lead to both crooked teeth and a smaller airway. So there is that relationship there, but there's a lot of resistance simply because a lot of the orthodontic techniques that we've been using really don't address the problem properly. They may straighten the teeth, but they often compromise the position of the teeth. I shouldn't say compromise, compensate the position of the teeth to match jaws that haven't fully filled out. One well-known compensation is the extraction of permanent teeth. You know, if the jaws have not grown up well enough that the teeth are crooked and crowded, removing a tooth is a way of providing room for all the rest. It makes perfect sense. And it certainly is a good technique if all you're concerned about is, you know, the straightness of the teeth. And it's been used for decades and decades. Well, now we're starting to see that, wait, if you have crowding of the teeth, that means you have small jaws. And if you have small jaws, that may mean you do have a breathing problem already. There are a lot of people that, you know, probably some of your fans that say, oh, taking out teeth, extraction of teeth in orthodontics is causing the airway problem. No, it's not causing the airway problem. It's ignoring the airway problem. It is operating just on that one piece, and that is on the straightness of the teeth, and it is not even considering, you know, the condition of the airway at that time. So those are two things there. All right, wait. Structure, function, behavior. So correcting structure means getting the jaws back to where they're supposed to be, helping them reverse their growth trajectory from narrow and shriveling to broad and wide. Here, can I show you? Let me show you these pictures. And what I'll share my screen and you'll put these up as part of
let's pull
the
that
test. Up. But yeah, you got to do this. And these are fine. And can you see my screen now?
Yes, we can see your screen.
See these two skulls?
Yep.
All right, fine. So these are two boys that walked into my clinic this summer, one on a Tuesday and one on a Wednesday. And I want you to look at the shape of the skulls. Let's start with the one on the right, the 7-year-old boy. His mom is a naturopathic physician. She brought him in because his front tooth was a little wonky, and she wanted to make sure everything was going to be okay. And I look at this. This comes from a 3-dimensional X-ray that we take called a cone beam scan, cone beam CAT scan. It allows me to look at the bones in three dimensions of space. I can, on my machine, I can't do it here, but on my machine, I can literally turn this around, you know, and see it from all angles, as well as other things. But look at the part of the jaw that's holding the upper teeth. Can you see how robust that bone looks, how strong it looks? And also notice the width of the nasal aperture, the part of that's his nose, and look how wide that is. And this boy's very healthy. Now, look at the one on the other side, the 6-year-old boy, and look at that same area of bone there. Look, can you see how? Can you see how? Literally, I'm going to say this. It's shriveled.
Mm.
It's kind of like a prune to a plum. It is. It's not dehydrating essentially, but it's not getting the kind of environmental stimuli that it needs for that bone to grow properly. Right? What happens to a plant when it doesn't get water or sunlight? What happens to an upper jaw when it doesn't have the tongue resting on the palate, when you're not eating food that requires chewing, when you have to open your mouth to breathe through your nose? And look at the shape of his nose. You see how narrow that is? Now, and this boy, 6 years old, mouth breathing, pees in bed at night, grinds his teeth. He cannot get good sleep, and his mood is horrid. I mean, he's kind of a nice kid, but you know, he like looks at his mother and growls. You know, one of those sort of defiant kids. And some of them are defiant. Some of them have attention deficit. This is very common in people that don't sleep well at night. And they don't sleep well at night because they can't breathe well. So then just this one more picture. This is what the roof of their mouth looks like. And you can tell the difference. The one on the right, that's a big, broad, beautiful palate with plenty of room for the teeth, and his tongue rests on the roof of his mouth. The one on the left is the sick boy who doesn't have his tongue on the roof of the mouth, and look how narrow the jaw is. It looks like somebody took a thumb and pushed it into clay, right? That indentation in the middle. Well, actually, that indentation is the only part that's correct. Everything else is collapsing in on it. And so this is, and Stephen, this is what I am seeing every single day. People that have good jaws, have good breathing spaces, like the one on the right. People that have their tongue lying low, can't breathe, their nose gets clogged, there's sinus infections, all this kind of stuff.
And
So,
love to add also too that the prevalence of the jaws of the picture on the right that you showed is getting much less, right? Like, how would you describe early in your career the types of malocclusion and the prevalence of it compared to what you see today? Do you think it's increasing?
Absolutely. When I was in school, so I give my age away a little bit. I went to ortho school in the early 80s. And at that time, we were told that 50% of the kids would have crooked teeth. And I said, fine, that'll keep me busy for my career, because that's a lot of kids. Well, now the epidemiology is that 75 and 80% of kids have crooked teeth. And you know, this is one generation, maybe two if you look at it that way, but you know, I'm still in practice and it's getting worse. What am I doing as an orthodontist that I'm allowing the problem to get worse, not better? You know, I mean, that's not our job, is to let things get worse so that we have more teeth to straighten. As far as I'm concerned, our job now, and this is where maybe I'm forward thinking, but it's not really my idea at all, is that we've got to become physicians of the face again. I mean, it's not a new idea. You could see it published in the literature in the early part of the 20th century. Orthodontists knew they had to be physicians of the face, and they worked closely with physicians. The fact that dentistry got separated from medicine, I think, is another reason why we wind up in this problem where we think teeth are not part of the rest of the body. You know what I'm saying? It's just another place where we've boxed ourselves into a corner.
On that, do you think that there could be, a new, type of orthodontic specialist born, like where there's, a different, maybe preventive, interceptive types of,
here I am. Yeah. That's me.
Yeah.
I want to work with kids, and this is, again, I'm standing on the shoulders of people like Herman Ramirez and Chris Farrell and John Mew, who has a, sort of a crazy reputation among standard dentists, but he had a foresight into the cause of the problem, and many people did. But there's just that inertia about, just put braces on and straighten his teeth and be done with it.
The clinical results are easier, right?
They're easier, yeah, and they're fun. I mean, I love straightening teeth, but I want to do it in a place where the teeth will match the rest of the body. Now I work with 3, 4, 5-year-olds, and I say, let's teach them, Jessica, let's teach them how to breathe through the nose, keep their lips together, put their tongue on the roof of the mouth, learn how to swallow, and then by the time the permanent teeth come in, there's enough room for them. And to be honest with you, it's in my hands anyway, it's not just MyoBrace. I also use palate expanders. I use palate expanders that are compatible with cranial growth and cranial motion. I mean, the skull bone, it's not just a piece of rock. It's a living, breathing thing, just like the rest of us is, and we have to treat it with respect. And there are techniques that do that and honor that. There are also techniques where I kind of force my will on the body, knowing that the damage has been so great and the distress that the patient is in is so significant that I can't wait around for the body to heal itself. I need to, get this patient down the road so that they have a chance to breathe well at night, and then let the body heal itself. That kind of thing. And there are many people out there like me, thanks to the shoulders that I'm standing on.
It's definitely a growing, arm of the field, isn't it? And it did have older roots, in the early 20s when, as, orthodontics was birthing this idea of the face. And you see in your scan that how, jaw development relates to the entire skull. The development of the orbits of the eye in the child on the left was affected. You could see the thickness of the zygomatic arches back to, and the support to the brain, the sphenoid bone. I've seen scans where in adults who expand their palate, the sphenoid bone changes. That's the base of the brain. It's remarkable, isn't it? How, and I really tip my hat to you, because I think that this is one of these kind of conversations need to be happening more and more every day. Or that problem that you've just showed us, it's not an easy one to fix. We see this in the clinic all the time, and there's a road to kind of fixing our next generations. And you're talking of a potential opportunity to prevent this as well. So look, let's dive into a little bit into your what you think parents should be thinking about in terms of pre-orthodontics. So you mentioned a 3 to 5-year-old. So What do you see that parents can notice in their 3 to 5 year olds, or to watch out for, and what kind of things do you do in your practice?
Yeah. So a lot of people ask this question, especially because I'm an orthodontist, and they'll say, well, when should my child start treatment? And generally, the expected answer to that question, no matter what your opinion is, has something to do with the teeth, right? So there are a lot of orthodontists that will say, oh, we don't really have to do braces until all the baby teeth fall out. And that used to be the standard of care, and in some places still is. And largely due to the fact that the mechanics of braces has gotten easier and more efficient, and we can do a lot to straighten the teeth. All right, I don't want to beat that dead horse, but or some will say we can start treatment when there's still half of the baby teeth there. You know, there's a dozen baby teeth. They call it the mixed dentition because there's half baby, half permanent teeth. And they'll do things like palate expansion and try to get the jaws, you know, back to shape. That's traditionally what's called early treatment. But the answer I have to give, I'm going to say, has absolutely nothing to do with the teeth. The answer I'm going to give is you start treatment when you discover the habits that are going to make the teeth crooked. And when you start learning to look for the habits, you see them, well, first of all, you see them everywhere. Kids are walking around with their mouths hanging open, their tongues low, they're not able to breathe through their nose and so forth. It is ubiquitous problem. So, but there are things that happen early on in life. We're now starting to look at things like how well can you lift your tongue up off the roof of your mouth, or is the string of skin underneath so taut that you can't really lift it up the way you should to have it rest on the roof of the mouth. We look at sleep as a really potent indicator of soft tissue dysfunction, because all the things that lead to problems with either the teeth or the airway, they are worse at night than they are during the day. During the day, we have ways of compensating and, you know, opening the airway. We open our mouth, we tip our head back, or put our head forward over our shoulders. You know, you don't see people struggling for air, you know, during the day, for the most part. But at night, when we lay down and we go to sleep and the muscles go loose and limp, that's when a narrow airway becomes a threat. And the body senses that right away. So in order to get to the next breath, because remember this, nothing is more important than taking the next breath to the human body. The body will adopt some kind of behavior to make sure that you do take the next breath. Could be opening the mouth, could be rolling over, could be tipping the head back, could be putting your butt up in the air and tipping your head to the side. It could result in things like fragmented sleep, waking up, having nightmares, you know, these parasomnias, as they call them. You know, we don't know this for sure. It's not really in the research, but I'm thinking that if somebody's having problems breathing at night, and most problems breathing happen during REM sleep, because that's when the muscles are the most flaccid, you know, and the airway tends to close up. If you're having trouble breathing at night, you're probably not dreaming about unicorns and daisies and blue skies. You're probably dreaming about somebody's chasing you, or you're stuck underwater and you can't get out, and you feel like you have to run or fly or, you know, get away because you're in fight or flight. Your body, when not being able to breathe well, gives you a shot of adrenaline that'll cause your heart to pump. and you wake up and you feel it, and you go, oh, that boss of mine, that husband of mine, that test I have to take. All these things, we put our mind to thinking about all the things that make us stressed out. It has nothing to do with that. Your brain is shut off. You're in panic mode because you can't breathe. So, I know, look, that may not be true for everybody, but when I hear those stories about poor and restless sleep and fragmented sleep, you have to rule that out. You've got to consider all that. So all these sleep symptoms are a problem. Now, there's a really good screening tool for that. And you may want to turn your listeners on to it. And you can find it at sleepinventory.com. It is a university validated sleep screening, and anybody can access it. Pay a few dollars and you get a 30-question questionnaire, and they give you a report. And there's one for let me see, it's 2 to 10-year-old, and there's another one for an 11 to 18-year-old. And you'll discover things that you may have not even noticed, or that your husband was saying, oh, that's normal, all kids do that. Well, it's not normal. It's not ideal. Maybe normal, but it's not ideal, and it's not an optimal way to grow. So what other things? At the dinner table, look for sloppy eaters. They're shoveling food into their mouths so fast because they can't take the time to chew before they have to take the next breath. They feel like they're running out of breath by sometimes talking fast is a sign. Watch them sit in front of the TV. If their mouth is hanging open, if their lips are apart, even if it's a little bit, you know the tongue is not on the roof of the mouth. Right? So there are lots of little signs like that.
You've talked about a lot of symptoms that relate to sleep, for instance. There are so many different professionals that are looking at how a child sleeps, but parents really need to be turned on to the fact that this is critically important for their development. And there are many different, and the way the jaw and the airway, like airway focused growth and development, this is how a child sleeps and grows, through the proper posture of their mouth.
Yes.
Well, there's when we're talking about tethered tissue, tongue ties, or for instance, if a child has adenoids and tonsils, how do you work? Because this is all starting to talk about a multidisciplinary approach to helping kids grow right. Yeah. How do you approach that, and what do you find that are common referrals between that works well with myofunctional orthodontics?
Yeah. Well, first of all, you have to realize that an orthodontist, a modern integrative orthodontist, which I try to claim to be, is dealing not only with the teeth attached to the child, but the child attached to the teeth. And as in my relegated role in society as an orthodontist, I can only do so much. I can train and I can do form and function in the mouth, but I can't treat the rest of the skull or the neck or the back. I can't look at fascia and treat it. I can't look at the spine and treat it. So, and there's even a specialty that teaches the four good habits for kids that say won't wear their myo brace the way I ask them to. They may need the help of a myofunctional therapist to train good oral rest posture and function, and maybe also speech and whatnot, because a lot of kids will have those speech problems. I may need the help of a cranial osteopath or a craniosacral therapist or a physical therapist or a chiropractor to help me balance the rest of the body. Now, sometimes the problems start in the mouth, they go to the body. Sometimes they start in the body, they go to the mouth. And so there is definitely a need for a collaboration between the orthodontist and and the rest of the body. We got to deal with allergies, so you need to have an allergist. We need to deal with the nose, which is, technically not in my wheelhouse, so we got to deal with pediatric ENTs. While I think that a lot of times I can shrink tonsils and adenoids simply by getting a child to breathe through their nose, that's not always the case. So sometimes the surgery is needed. What else? Allergies, sleep, and yeah, some people are really in such trouble with sleep they really need to deal with that first. We find that's more true for adults than it is for kids, but if you have true sleep apnea, that's a medical problem. So there are a lot of us that are working on this collaboration piece. In fact, there was just the 5th annual session of the American Academy of Physiologic Medicine and Dentistry, whose job has been to bring dentists and physicians together, talking about airway, and breathing for some years now, very successfully. And now you'll be happy to know this, Stephen. You may already be aware that they're also getting into the areas of nutrition and inflammation and microbiome and how the biochemistry works. I think that in time, as these ideas become more well accepted, we'll also start looking at the energy systems in the body. Western medicine hasn't looked very favorably on some of the energy therapies yet, but to my mind, there's a lot of evidence suggesting that there are energy circuits in the body, physical ones, not just, chakra and meridians, but these have real compelling physical underpinnings in the body, in fascia in particular. Fascia is a structural element of the body. It gives it its shape. It also is an information conduit because it can transmit light as well as electrons, and at the speed of light. I mean, the more I learn about this, the more I realize that the biochemical explanations of the body just do not answer all our questions. And just relying on nerves alone, they are too slow to do ballet or, rugby.
It's a fascinating way to think about it, because you mentioned that orthodontics is based on Newtonian physics. Well, Newtonian physics, the very basis of our reality is being outdated, or is outdated,
Yes.
by nearly 100 years. And we know that the subatomic world is basically dissolves to energy when you zoom in fast enough. That there are many different strange ways that that this very small world behaves, and that a lot of the Newtonian, nearly all of the Newtonian laws don't work down there. So, and that's within us as well. So it is a very there is a big problem ahead of I think humanity in general, in understanding, one, the human body, but then two, the nature of our environment and how all this comes together. It's fascinating that you brought that together. I've been looking at the same thing. I really think that that's one of the really important points that we need to bring together, is that our biology is governed by the biology of our surroundings and the laws that it abides by. And until we really understand that, then we need to get a hold of this whole picture.
All right.
Harry, you mentioned adult treatment.
Huh?
I
want to finish on that last point. I know we only have a couple minutes left, but one of my mentors, Gavin James, is talking about quantum orthodontics based on quantum physics. And it's not an either or. It's not that you have to say we're not biochemical or we're not mechanical. We are. And the world does abide by Newton's laws of physics at a certain level in certain conditions. But we also know that the way we look at the world also depends on what we see. This was the Heisenberg uncertainty principle from 100 years ago, and I really think about that. You can see the body as an energetic being, or you can see it as a mechanical being. They're both relevant, and they both have their place.
Absolutely. And the idea that we control energy in order to control the mechanics, there's a lot of I think, applications. And these are all, well, for the most part, being shown to be able to be proven with scientific research.
Yeah.
So and it's just so disparate that it's very difficult to put together. With a dental degree or a orthodontic training, bringing these kind of principles in takes a long time, right? So there's kind of a bit of a lag between what's happening out in the world and even the scientific community in general, and then what's being applied to our health sciences.
That has ever been thus. Stephen, you promised to ask me back again in 10 years, and maybe we'll be able to move this ball down the road a little bit further.
Let's say, yeah, we're definitely going to do that. Let's say 5. I want to touch that point before we start to wrap up. I just wanted to, if you can describe a little bit, because we've talked about kids a lot, but is there hope for adults, and are there modalities of myofunctional orthodontics for adults?
Yeah. Is there hope for adults to learn algebra, to learn how to dance, to learn how to play guitar, to learn how to eat right, to learn how to breathe right, to learn how to be physically fit? Of course. I mean, it's harder for us as adults to unravel all the damage that's been done all through the years, and sometimes the treatments for adults have to be a little more aggressive, if I have to say that. But when you open an adult's airway, take somebody back from the brink of OSA and open their airway and give them a good night's sleep, they will be forever thankful.
Absolutely. And so is that with maxillary expansion? Do you find that's
yeah, we have ways of expanding maxillas in adults. It's similar in a way, similar to kids, but the bones are not as malleable and growth is not there, but that doesn't mean it can't be done. Maybe it requires some surgical intervention, and there's a lot of progress being made on types of expanders that can be used for adults. I've seen some amazing work up until, I don't know, 6th, 7th decade of life. Our bones are living things, and they can be altered.
Absolutely. We mentioned the future, Dr. Raphael. How would you like to see, say in 5 years' time? We'll definitely plan our meeting back in 10 years. But how would you like to see, what progress would you like to see in the next 5 years in terms of how we perceive this idea of the growth and development of our children's dental art?
Where we need the research the most is not so much knowing about what makes teeth crooked. We need to know about what makes teeth straight in nature if they were to grow straight naturally. What is it that we lost? What do we have to recapture to be able to encourage a body to grow in its fully optimal shape and form? And once we do that and start to mimic it, then we're going to make real progress. And there is a potential that after a few generations of doing that we can undo this chronic problem as well as other chronic diseases that we've been facing.
I love the idea of getting in front of the issue, and I've got a 2.5-year-old and an 11-month-year-old, and currently going through the process of trying to make sure that their arch develops properly and putting the right things in. So it's great that we're thinking in this way, and that the message is that we can absolutely change our future generations health trajectory. And it's so amazing that you've gone through this process yourself, and that the way you're speaking about the dental arch and that the way you're helping your patients. How can people come and see you, and where can they find you on the internet?
morethanstraightteeth.com. That's where I lay out my protocols, how I look at things. I have a really good flow chart there that'll take you step by step through assessment, and behavior management, and biomimetics, orthopedic remodeling, and interdisciplinary treatment. And And then, of course, how to straighten teeth on the side. That's the icing on the cake.
It's it's so fascinating to see this kind of start to live and actually kind of help and change the future health of our next generations. Dr. Raphael, I just want to thank you so much for your life's work, and that how much passion you share for this information, because it's not a difficult problem that you're addressing, and it takes a long time and a whole career. So it's a testament to your own your own commitment to understanding what is happening with your patients. I just want to thank you very much for that, and then let's definitely plan another talk. Definitely not in 10 years. It'll have to be sooner than that.
All right. And I want to thank you too, Stephen, because you're one of the young guns that's going to come up in the new generation and make things different for everyone.
We can change things. Dr. Raphael, have a great night. I want to thank you again for sharing some time with us.
All right. Good night, Stephen.